Thanks, Dr. Prabhatani. So I was asked to present about just general tips managing diabetes and potentially new evidence that we have. I do have to disclose that I'm a co-investigator in the Metformin in women with type 2 diabetes in pregnancy, or MIGHTY trial. This is funded by the CIHR, and I don't get any pharmaceutical benefit or medical device or communications organization. So the structure of this talk will be essentially reviewing glycemic targets for those with type 2 diabetes, which will be familiar to probably everyone, discussing available agents to achieve glycemic targets for type 2 diabetes, and reviewing current literature, particularly the cardiovascular outcome trials that have come out recently in this area. This slide is really just for your reference to review the screening guidelines for type 2 diabetes. Of course, you should screen every 3 years individuals who are older than 40 years old, usually with a fasting plasma glucose or a hemoglobin A1C. Very rarely you do have to go on to do a 75-gram oral glucose tolerance test. And this particular slide is available on the Diabetes Canada website under the guidelines. And there's also a guideline app, which is very accessible and nice to have on your smartphone. So this, again, is just a review of the A1C target. This is a reminder that for most of our patients, hemoglobin A1C should be under 7%, not less than 6%. And for some patients, particularly frail elderly patients or patients with chronic illness, the A1C may creep up to about 8.5%. And in those who wish to achieve pregnancy or who are able to have tight control without adverse effects, you can target a lower A1C. The big message with this slide, and the big message from Diabetes Canada in the last couple of years, has been essentially individualizing care and A1C targets for individual patients. So rather than looking at what the medications are and what the medications could do, you need to look at your patient first and then choose a medication based on that. So I've made this talk case-based just to try to keep our interest levels up. So this is Mr. Brandon. He's a 75-year-old man. He's had a recent diagnosis of type 2 diabetes. Medical history is significant for hypertension, chronic kidney disease, and he had a hip fracture last year. He presents with worsened glycemic control in recent months. He's using metformin 1,000 milligrams POBID, sitagliptin 100 milligrams POOD, and despite this, he reports daytime sugars, which range between 9 and 12. His blood work is significant for creatinine of 240 and an eGFR of 25. His A1C is about 8.8%. So the question I want you all to consider is, what adjustments should you make to his anti-hyperglycemic regimen? A, in addition to his current therapies, add gliclazide. B, dose reduce his metformin, continue sitagliptin, and add dose-reduced gliclazide. C, discontinue metformin and sitagliptin, and add linagliptin and dose-reduce gliclazide. Or D, discontinue metformin and dose-reduce the sitagliptin to 25 milligrams daily. I deliberately made this a bit detailed so that it would make you think, because I'm sure you're all managing diabetes all the time. So the initial therapeutic agent in type 2 diabetes is metformin. Thereafter, the choice of therapy should be individualized based on the patient characteristics. And the things that Diabetes Canada is encouraging you to consider is the degree of hyperglycemia. So for example, for Mr. Brandon, his A1C is 8.8%, but he's got chronic kidney disease and he's recently had a hip fracture. So those are important things to consider for him. Risk of hypoglycemia, if the patient is overweight or obese, if there's any cardiovascular disease, if there are comorbidities including renal failure or CHF, and then probably most importantly, patient preference and feasibility, access to these medications, because of course they do all come at different costs. This slide I can appreciate is probably a bit hard for you to see. Again, it's from Diabetes Canada. This particular slide was updated in 2016 and does show what the options are other than metformin, and it's actually done in quite a user-friendly way. So you can see what the relative A1C lowering is, what the effect on weight is. The actual cardiovascular outcomes are summarized here, and then other therapeutic considerations. So for example, if you're considering giving somebody pioglitazone and you know that they have a history of bladder cancer or CHF, you might reconsider. This is a slide that I personally keep handy on my phone really all the time. It again was updated in 2016. And you can see the green lines indicate the safety of these agents down to an eGFR. Yellow is at what point you should reduce the dose, and red is when it's contraindicated, and the stripes are just when it's not recommended. Most agents, as a rule of thumb, are safe with an eGFR greater than 60. That's just a number to keep in your head. And then you can see when you're considering this case in particular, if you look at metformin, it's contraindicated with an eGFR of under 30. If you look at sitagliptin, you can use it safely at 25 milligrams all the way down, etc. So back to this case, he's an elderly man, he's frail, he's broken his hip, he's on 2 agents, but despite this, he has poor glycemic control and his eGFR is 25. So what adjustment would you make to his regimen? Many of you are probably thinking I would just switch him to insulin, but that's not an option. So I chose C, to discontinue the metformin and the sitagliptin, and that's because, again, the metformin is contraindicated, making A and B wrong. And then D is definitely an option, but it's doubtful he'll achieve his glycemic target, even an A1C of 8.5, with just 25 milligrams of sitagliptin alone. So in that case, C was the best response. Okay, challenging case number 2. So Ms. Bennett is a 42-year-old woman with an 8-year history of type 2 diabetes following the birth of her second child. She presents for routine follow-up. She has class 2 obesity with a BMI of 36. She reports infrequent monitoring of her blood sugars and states that she's generally stressed and fatigued. I can't tell you how many times I've heard this story. She does not engage in physical activity. She's using metformin 1,000 milligrams POBID and gliclazide 120 milligrams daily. Her laboratory investigations reveal creatinine of 80, eGFR is 90, and her other blood work is normal with an A1C of 7.9%. So in her case, what adjustment should you make to her anti-hyperglycemic regimen? You could discontinue the gliclazide and add sitagliptin. You can add pioglitazone. You could add empagliflozin. You could discontinue gliclazide and add liraglutide, or you could start insulin. So the point of this case really is to highlight what the options are for patients who are overweight. And I think in diabetes care, obesity is really at the foundation of a lot of the difficulty that our patients have, and it's important to consider what the agents we give them really do to their weight. So one class that's weight neutral is called the incretins. So incretins include DPP4s and GLP-1s. This slide is just to summarize essentially that the effect of GLP-1 is to increase beta cell proliferation in the pancreas and also to decrease hepatic glucose production. And I didn't put it on here, but it also has an effect on appetite stimulation in the brain. And so sometimes patients who are on GLP-1s have a lower appetite as well. DPP4 inhibits GLP-1, so when we give a DPP4 inhibitor, all we're doing is allowing endogenous GLP-1 to last longer, and so you do not give these 2 medications in combination because the effect would be redundant. Available incretins to date include the DPP4 inhibitors, so linagliptin, sitagliptin, saxagliptin, and alogliptin. And GLP-1s, of course, are Byetta and Victoza, or exenatide and liraglutide, as well as albiglutide and exenatide. This is an image of SGLT2 inhibitors. I'm sure everybody's heard of these now, but they've actually only been around for about 4 or 5 years, and they work in the kidney. This is my interpretation of the nephron, so it looks like in my head. So essentially, SGLT2 is in the proximal tubule, and instead of having blood sugar be stored in fat cells and muscle cells, this allows our patients to actually pee the glucose in their sugar away, in their blood away. And so SGLT2 is blocked, and 90% of glucose reabsorption is stopped, and 10% is still absorbed through SGLT1. The reason we can't block SGLT1 is that there are SGLT1 receptors in different tissues, including cardiac tissues, respiratory tissues, and gut tissues, and the GI side effects are completely unacceptable when you block SGLT1. Patients have profound diarrhea. So there are 3 available in Canada at the moment, Invokana, Forxiga, and Jardiance, or canagliflozin, dapagliflozin, and empagliflozin. They all have excellent A1C lowering, and they all are weight neutral or cause weight loss. That is actually not on this slide, but they do cause weight loss. The side effect profile can be pretty hefty, and so it's important that you remember to counsel patients about the risk of dehydration, because you have to remember they're peeing now a lot, and also the risk of GU infection. So suddenly there's a lot of sugar down around their genitals where there probably wasn't before, and so I always counsel people to just add an extra daily hygiene there. So Ms. Bennett is 42, and she's got the 8-year history of diabetes. Her main issue is her class 2 obesity with a BMI of 36, and her A1C, which is over target at 7.9. What adjustments should you make to her anti-hyperglycemic regimen? You can A, discontinue the glycoside and add sitagliptin. B, add pioglitazone. C, add EMPA. D, discontinue the glycoside and add liraglutide. Or E, start insulin. Haha, gotcha. So the reason I did this is because I just wanted you all to recognize that sulfonylureas actually cause weight gain. They are not weight neutral, and they certainly are not associated with weight loss. And so option C, which would allow for weight loss, still leaves her on an sulfonylurea, which may be not too helpful for her. So I discontinued the glycoside and added liraglutide. I don't know. She does. She's fabulous. She's wealthy. Yeah. Okay. Okay. So case 3 is Mrs. Price. She's 69. She's had type 2 diabetes for 12 years. She presents for annual blood work. She's got a history of coronary artery disease and had a CABG in 2015. She also has hypertension, and she's an active smoker. So I have to do some strategies for that, I guess. To date, she's on metformin 1,000 twice a day, sitagliptin 100 a day, and pioglitazone 30 a day for her diabetes. She's also on a number of medications for her CAD, including perindopril, metoprolol, and rosuvastatin. You note that her blood pressure is still elevated at 152/70, and otherwise her exam is significant for a BMI of 38. Laboratory investigations reveal normal CBC and lights. Creatinine is 112, eGFR is 60, and her A1C is 7.9. So what adjustment would we make for Mrs. Price? You can start her on basal insulin and increase it by 1 unit each night until her fasting sugar is under 7. You can add liraglutide, you could add EMPA, or you could add glycoside. Which brings us to the cardiovascular outcome trials. So there actually have been a number of these trials done in the last certainly 10 years. I'm only going to talk about 2 of them, but I have provided a summary slide of what the outcomes have been in all the rest. So if you'd like a copy of this material, I'm happy to provide it, and hopefully that'll be a good reference. So the first one is EMPA-REG. This one was published in the New England Journal of Medicine in 2015 and was a very large trial at 590 sites, 42 countries. And it had 7,000 participants who were each assigned to a different group, either empagliflozin 10, empagliflozin 25, or placebo at a 1:1:1 ratio. I have summarized the inclusion and exclusion criteria here on the slide, but what I want you to really take from it, and sorry again, this one's hard to see, but what I want you to really take from it is the number of patients enrolled in the study who had cardiovascular disease. So 98 and 99% of patients in every group had a cardiovascular risk factor. Coronary artery disease was present in 75% of patients, multivessel disease in about 47% of patients, history of MI in about 50% of patients, history of stroke in about 25% of patients, heart failure in 10%, etc. So this is a high risk group. It doesn't apply to patients who have never had cardiovascular disease, but it certainly is important for anybody you're considering secondary prevention in. So these are the outcomes. The primary outcome was a composite outcome of cardiovascular death, non-fatal MI, and non-fatal stroke. And there was a significant reduction in the empagliflozin group versus placebo group with a hazard ratio of 0.86. Death from cardiovascular cause was again statistically significantly lower with a hazard ratio of 0.62. Death from any cause significantly lower with a hazard ratio of 0.68. And hospitalization for heart failure, again, statistically significantly lower with a hazard ratio of 0.65, so pretty profound outcomes. This is just an A1C table. The reason I included it was to show you guys that there actually is not that much difference between the A1C lowering of empagliflozin 10 versus empagliflozin 25. Obviously, both are much better than placebo, but they're not that different from each other. They also looked at renal outcomes. So the first one was incident or worsening nephropathy, and the EMPA group had a lower rate of worsened nephropathy with a hazard ratio of 0.61, and that was statistically significant. And they also had a significant reduction in a renal composite outcome. So the composite was advancement to dialysis or renal replacement therapy, death from renal cause, or doubling in serum creatinine. and that one showed a hazard ratio of 0.5. So again, pretty significant. So that's empagliflozin. That leads us now to LEADER, which is liraglutide, or a GLP-1. This was another enormous study, 410 sites, 32 countries, 9,000 participants. And in this case, they either got liraglutide 1.8 or they got placebo. Again, I've included the inclusion and exclusion criteria here on the slide for anybody that's interested. The baseline characteristics of this group, there was actually a little bit less established coronary vascular disease. So in this case, 80% of participants had cardiovascular disease and 20% didn't. This group was also different than the EMPA-REG trial because there were people included here who had renal dysfunction. And so they did have patients involved in this study who had moderate renal impairment and even severe renal impairment. So the outcomes here also showed that liraglutide, with the same primary outcome of non-fatal MI and stroke and cardiovascular death, had a reduction in that outcome with a hazard ratio of 0.87, reduction in death from cardiovascular cause, trend towards reduction in non-fatal MI and non-fatal stroke, but no statistical significance there versus placebo. Death from any cause was lower in the liraglutide group, and hospitalization for heart failure was non-statistically significantly reduced. They did also look at microvascular events. Retinopathy was not significantly different, but nephropathy was, again with a reduction in rates of nephropathy. They also looked at A1C lowering, so the liraglutide group lowered A1C by about 0.4%. So if we're thinking about our case patient, Mrs. Price, her A1C is 7.9. So if we start liraglutide, she'd be at 7.5. Body weight was reduced by about 2.3 kilograms over the 48 months. Systolic blood pressure was lowered by 1.2. Diastolic blood pressure was actually increased 0.6. And heart rate was increased by about 30 beats per minute. So this is the summary slide. Oh, no, sorry, 3 beats per minute, not 30. 3. Sorry. Whoops. Okay, this is the cardiovascular outcome trial. So this is the summary slide. The big ones for you guys to keep in mind, obviously, are EMPA-REG and LEADER. CANVAS was another one, which did show a reduction in a cardiovascular composite outcome, but it also showed increased amputations. So there is some concern now about canagliflozin and amputations from this study. SAVOR-TIMI was one that was done in a DPP4 with saxagliptin, and it did show increased heart failure hospitalizations. The others were essentially neutral. Sustained 6 may have had a benefit in non-fatal MI, but otherwise they were fairly neutral. Okay, so back to Mrs. Price. She's got the long-standing diabetes and the CAD and the cabbage. She's also overweight with a BMI of 38, and she's using metformin, sitagliptin, and pioglitazone at the moment. So what adjustment are we going to make? Okay, so I chose C, the reason being that she's already on Januvia, which is a DPP4. So remember, you can't give the DPP4s and the GLP-1s together, so that's the only reason that B is not the correct choice. But C is correct. And insulin and glycoside will both cause her to gain weight, and they won't provide her with any benefit from her cardiovascular standpoint. So Diabetes Canada did release a statement saying that the presence of clinical cardiovascular disease and the effect of antihyperglycemic agents on CV outcomes should be considered a top priority in choosing add-on treatment regimens for patients with type 2 diabetes. The algorithm for management now recommends that an antihyperglycemic agent with demonstrated CV outcome benefits, such as empagliflozin or liraglutide, should be added if glycemic targets are not met in patients with clinical cardiovascular disease. So that's a strong recommendation. I did have a fourth case with insulin therapies, but I don't think we have time for it. So I will just mention that there's a new ultra-fast-acting insulin called FACP, which has been available since March. And there's also a new insulin called Degludec or Tresiba, which just came on the market last week on October 2nd. And that one lasts for about 48 to 72 hours. So that's the marketing strategy with that. There are new Diabetes Canada guidelines coming in April of 2018, so keep your eyes peeled for those, and they'll probably reference some of these trials. So in summary, the choice of A1C target is 7% for most Canadians, but could be individualized. Metformin remains the first-line oral agent in Canada. choice of additional agents really should be individualized based on factors like desired weight loss, history of particular malignancies, metabolic bone disease, CV disease, etc. And cardiovascular outcome trials have demonstrated cardiovascular benefit for EMPA, canagliflozin, and liraglutide. Thanks.